Continuing our discussion of evidence-based therapy, we're going to now discuss the quality of evidence, a pyramid of evidence, level of evidence, and then go on to develop a checklist that you might try to apply as you look at the literature about any new drug or therapy. Okay, when we talk about the quality of clinical evidence, we think about it both from the quality, carefulness of the study, but also the relevance of the study to a clinical patient. And so what we're showing here is what we call a pyramid of evidence. And the pyramid of evidence starts with finding that drug down here in a test tube and saying, hey, it works on that right receptor. And then we go to, it maybe works in a rat or on a tissue or tissues from a rat or some species not of the target species, not a dog, not a cat, or in the case of human medicine, not a human. And then so these obviously have very broad, they're important basis to what's going to come to be more clinically relevant types of reports. But this gets to where you start seeing where people, practitioners will say, hey, I've seen a couple of cases and I've tried this drug, an editorial, an opinion piece, or a consensus report. These are not as high quality because they are opinion. They are not about carefully designed studies. Then you get the case report or the case series, whether they're controlled or not. Now the next categories, case control study and the cohort study, really are not used so much in pharmaceutical research as they are in epidemiological research. So we will show an example, more specific examples of drug studies in the next couple of slides, including a higher, sort of the gold standard for a single study would be the blinded randomized controlled trial, RCT. And then when you start taking a series of these studies, a randomized controlled trial, and you summarize them, or you take a piece of data from, say, 5 or 6 or 10 of such studies, and you don't really see this often in human medicine, where there are the funds to do this kind of research, you'll see a meta-analysis. And I'll point out there are a few in veterinary medicine, but very far between. And then we get to the systematic reviews, which are literature research reviews of the literature on randomized controlled trials, exhaustive literature research studies. And so obviously, as you go up the pyramid in the clinical realm, the numbers of cases go up from a single case study, case report, to a case series, to a blinded randomized controlled trial, and then meta-analyses and systemic reviews. Okay, let's take a look at the nuts and bolts of a randomized controlled trial. And so we start out here in the left-hand side, and we see that we have a target population. There's the healthy part of that population and the disease part. Obviously, you start with patients with that disease. And then you say, I'm going to randomly allocate. This is all done ahead of time by some procedure, usually by a computer, that randomly allocates them to a control group or to a treatment group. And then both of these groups, totally separate, are hopefully with similar characteristics from the standpoint of age, breed, sex, etc. They're treated, and then there's a follow-up period, and then statistically the outcomes are compared. So that's a randomized controlled trial. If you add blinding, as I said, the blinding part leads to the person who's making the allocation here, the person who's doing the treatment here, in our case, the owners, are totally unaware of what the treatment might be. Now, another type of study that you'll often see are called crossover studies. And basically, the advantage of a crossover study is, particularly with regards to looking at treatments, we call treatment A and treatment B in this case, is that you can compare those treatments in the very same patient. That reduces inter-individual variation. This can be very significant. The problem with this is you can imagine that you can only use this kind of treatment in a condition that doesn't get cured by the first treatment that's being applied. And so you might use it with regards to managing congestive heart failure. But you probably wouldn't use it to try to manage a urinary tract infection, because you might find that the first drug cures that infection. So the same thing, we start with the patients with the condition, randomly allocate those to group 1 or 2, and we have patient, initially the patient gets drug treatment A or B, and then they're assessed at that point, and then they're flipped. They're washed out. There's usually a period of time where that drug needs to go away. They come back to some degree of baseline, and then they're treated with the other drug. And so the inter-individual variation, the variation of their disease, the variation of their physiology, their drug metabolism, all of that gets factored out. But the weak point of a crossover study is that the disease itself could possibly change over that period of time. But you have to decide ahead of time whether that's a reasonable bet to make. Okay, now let's take a look at the strength of drug trials. And what do we mean by that? Well, we have the categories that we talked about, starting at the highest level, the randomized controlled trial, and then we have a trial that might either lack blinding or randomization as a slightly lower tier, then an open uncontrolled trial, meaning that a drug is tried but it's not compared to anything, a placebo or another therapy. And then we have the cohort study, the case control study, descriptive study, or case report. And notice as subcategories for each of these, we have as the highest level, and this has been developed by a group of researchers who are veterinary dermatologists, and they've sort of led the way in meta-analyses of therapy in dermatological conditions. And notice that the numbers of cases, here they have the highest level in veterinary subcategory would be over 50 subjects per group, middle 20 to 50, and lower 10 to 19, and the lowest less than 10 subjects per group. And that's true for all of these as subcategories. But notice the numbers of subjects per group for study compared to what you would hope would be the case for human medicine if you or I were taking a drug. I always ask students, I said, when I would ask you, would you take a drug if you knew that only 50 subjects had been given that drug, and regardless of the strength of the evidence, we're really talking about safety and efficacy when that is the small number that has been applied to even a randomized controlled trial. So in veterinary medicine, because of the lack of funds for research, particularly if we're talking about drugs that are not being put through the FDA process, we have a small number of cases. And therefore, we have to be prepared as clinicians to realize that we're still learning about drugs when we get them provided to us, even after they've made the FDA standards. But certainly, if we're using a drug that is off-label or not for that particular indication. So you just have to be aware of that. So this somewhat busy table is really here to demonstrate one equine clinician's effort to try to score the quality of a study for the purposes of treating a horse. And so you can see what they do is they start with the highest level being an FDA-approved drug for a horse, and then maybe an FDA-approved drug that was for some other species being used in a horse, and it goes from 10 to 8 in terms of the quality of that data. Not the quality of the data so much, but the quality of it's being applied to a horse. And then if they, as you go down the list here, look at the other highly scored things. If it's an approved dose, that's a high score. If it's an intended route, that's a high score. If it's a label claim, meaning we're treating an infection of the lungs, and that's the label claim, then that's a high score. If it's not a label claim, it would be a lower score. So, and of course, unregulated things like herbs, he's giving no score to that, homeopathic preparations, etc. So I think this is and one other thing to make a point about, if there is just some data with regards to the dosing where a drug has been applied that's not FDA approved, but they've done a pharmacokinetic study, that gets you halfway there in his mind to at least understanding the right dosage for that drug in a horse. And this is crucial because we will talk in this course about how we determine drug dosing based upon pharmacokinetics. So, of course, down the list are the earlier studies we talked about, which are laboratory studies in cell culture or in an animal like a rodent. So now I'd like to turn to the use of evidence-based medicine in practice, and I borrowed from Virginia Fate, who's a clinical pharmacologist, from her paper in the Journal of Veterinary Medical Education in 2009. In a clinical scenario, what you want to do is to devise answerable clinical questions. What's relevant to you as a clinician that you can answer, and then locate the best evidence, and then appraise that evidence, and then integrate that evidence with what you know as a clinician, as well as the patient's and the client's circumstances. So the patient, might be old, therefore you can't use this drug, or the drug might be supremely expensive, and the client may not be able to afford it. These are all later considerations that are part of deciding whether, even with good evidence, you should use a particular therapy. And fundamentally, I said earlier that evidence-based medicine is an ideal. It's many of you would maybe have said, I've never seen this used in practice, I never see it used consciously or openly by a clinician. And practicing evidence-based medicine requires application of appraised evidence, but also common sense, meaning you can't be paralyzed if you don't find all of the data you think you should have for a treatment. You need to do the best you can. You need to do your literature research and understand that what you're applying in this case is the very best evidence that you have in front of you. And then the rest of it really is you being a good comparative pharmacologist. So now I'd like to end with some validity questions for any particular study that you might read in the literature. And I think Dr. Villar is going to be working with you in this course on the certain papers where we talk about the papers from the perspective of what kind of quality of data do they provide to us for drug therapy. So the first one is the research question clearly stated? Even in a drug study, did they select the study patients in a way that there wasn't bias? Is there some selection that make sure that you get a good homogeneous population that isn't impacted by you're deciding that, you know, dogs of this breed should go in one category and not another. Therefore, that leads to the study groups. Are they comparable? Was there stated a way of, ahead of time, what are called exclusion criteria, and how are those animals excluded or those patients in the study withdrawn from that study? They have to be carefully defined ahead of time. Was blinding used to prevent the introduction of bias? We talked about that. The blinded people need to be the clinician, obviously the client, and anybody evaluating, say, the pathology or even clinical pathology. And then were intervention of therapeutic regimens and any comparisons described in detail? Were there any intervening factors described? Were there any things that made it not so clear-cut a study? Getting to the results, were the outcomes clearly defined and the measurements valid and reliable? And you'll get better at this over time, but you know, were the appropriate statistical procedures used for the study, and were the outcomes the appropriate types? And then were the conclusions made by the authors supported by the results? And did they notice or did they make comment of, in their discussion in particular, of any biases and limitations of a study? There is no real study that is perfect. And finally, and this is important really to note right up front, is there possible bias to this study because the drug study was funded by or sponsored by a company that might have a vested interest in having this result of this study for that drug come out as a positive? And this gets to the overall tendency in the literature for mainly positive studies to be reported. And so you can imagine that this gets to be even more likely in the case where a drug company might have funded the study and might have written something into the contract that says they have the last word on whether that study is approved and published. And of course, when you hear that, when you see that, you have to realize that indeed there could be bias implicit in the paper that you're reading. Okay, so those are the criteria we want you to apply to thinking about clinical cases. We want you to think about evidence-based medicine. We want you to try to use Pac-Man to try to bring the best data forward, understand the quality of the literature, and we'll talk about that as we talk about the cases, as we start to use a formulary together. We'll come up upon different kinds of papers, and we'll explain the difference between those. And in the next video, we are going to talk about a case, so there will be clearly outlined which studies of higher quality than others.